to look at it and listen to what was discussed. So we are going to ask our colleague from Viga to come forward and lead us in a word of prayer so that we can go on to the agenda of the day. Welcome.
Okay, let us all bow down for a word of prayer. Father, in the mighty name of Jesus, we come before you this morning. We thank you, we exalt you, we lift your holy name because you're mighty. We thank you, Lord, because you've enabled us to see a new day. We don't take it for granted, but return all glory and honor to you. As we want to begin this new day, we pray that you may guide us, you may protect each and every one of us. May you grant us wisdom, may you grant us good health. May you lead us through the discussions, may you give us insights. That, Lord, when we go back to where we came from, Lord, we may be able to improve the quality of care for the people that we serve. Father, I want to thank you for each and every presenter, for each and every person who is supposed to be in this place today. We commit them in thy able hands. Father, I want to pray, Lord, even for Nairobi. We want to pray, Lord, that you may also send your showers of blessings of rain in this city so that your people may experience the good weather. We thank you, Lord, even as we continue, and at the end of the day, we pray that you will be with us. In Jesus' name, I do pray and believe. Amen.
All right. Thank you very much. That is really appreciated. And we pray that the blessings of the rain that are already pounding parts of the country, especially the western side, shall also come to Nairobi and to the rest of the country. Yeah. So today is a very special day because the focus of today is basically the implementation research element of the work. And as was already presented yesterday, we've done all the work that we've done in terms of the 3 work streams. Many presentations were made yesterday, many speeches were made. But I just want to highlight a few things before we go into the business of the day. So, based on the many speakers that stood here before all of you yesterday, I think the general impression that we got is that all of us are committed to ending preventable maternal and newborn deaths. And I think all the work that we do is to be able to advance that agenda. Whether it is the government, whether it's the development partners, implementing partners, ourselves as members of the community, in our small practices, wherever we are, our agenda is to ensure that no mother needlessly dies during birth and childbirth. We also know that SRM and CAH per se remains an agenda for the country. It is actually a priority. And so much has happened in the last 10 years. Extensive investments have been made. And we celebrate the gains that we have made as a country, but we also acknowledge that there is unfinished business that needs to be addressed. We also note that the devolved system of governance, the counties, are very critical to ending inequities, inefficiencies, and the poor outcomes that have already been documented as far as MNH and SRM and CH in the whole spectrum is concerned. So, and also we need to note that we live in different times. There is the aspect of climate change. And just as we are praying for the rain now, we must know that going into the future, everything that we do, we must also consider how does climate change impact the work that we've been doing, whether it is utilization, whether it is access to services or outcomes for the mothers and newborn. How does the changes in temperature, whether it is by 1.5 or 1 degree over the last few years or going into the future, how does that impact that? We will not do business as usual. We need to think, we need to also capacity build ourselves. The same way we build our capacities in EMONG and in MPDSR and the others, we must be able to capacity build ourselves to be able to see the link between the climate change and how all that pans out in the space in which we work. We also know that over the last 5 years, in the context of SDGs, globally, not much progress has been made in terms of maternal mortality ratio. And of course, the trends basically remain the same. So, for instance, for Kenya, whether we look at the KDHS 2014, which said the MMR was 342 per 100,000, and the current modeled number of 355 from KNBS, the difference is not statistically significant. And maybe when we look at the estimate that the WHO and other global bodies have given of 530. Of course, we may get concerned, but even if we were to follow that one, the trend is still the same. The difference is not going as we should be. So, and from this we learn that it is very important as a country to have a robust civil and vital statistics system that really documents all these deaths as they occur, so that when it comes to modeling it, it is not, we are using a gold standard and not having figures that are variable from others and therefore not easily comparable. So we hope that going into the future, we will continue as a country to put investments and effort in the central and civil and vital statistics, so that all these events are well documented and we can just count the numbers and easily compute that number. We also learned that sustainable interventions calls for participation of all. The ministry, of course, issues policies, strategies, and guidelines on how things are to be done. The implementation is at the county level. That is where the service delivery takes place, and the leadership of the county departments of health. And of course, as the many other players, development partners, implementing partners, we just feel into that space. And we hope that by coming together, we can be able to strengthen the outcomes for mothers and newborns. And finally, it is important to always remember that unless there is political goodwill, you can have all the good ideas, we can have the research findings, we can even translate it to policy guidelines, but unless there is goodwill to take it forward, then chances are that we may find ourselves just talking and not much happening. So to be able to crown all this, today we shall go into the realm of evidence. What is the evidence showing? And especially looking at the work that has been done, whether it's in the in-service, in the pre-service, or the accountability for maternal and newborn deaths in the form of MPDSR work. And the approach to work for today, starting now, is that we are all going to go into 3 working groups according to the area of interest or how you've been participating in this particular project. We have the MPDSR work stream, the in-service and the pre-service. For each work stream, there is a session chair, and then there are couple of presenters. So starting this morning, we will have, the first session will be 3 presentations for each work stream. So you will have your session 1, session 2, and session 3. When you come to, at the end of session 3, in that particular work group, in the particular room where you will be, the presenters will form a panel, and the participants will then engage them in forms of questions and answers to clarify the data, the conclusions, the recommendations they are making, and maybe generate a dialogue around how this can then be taken up into policy conversation to be able to impact the lives of mothers and children. Once that is done, then at 10:45 to 11:15, there will be a tea break, a health break for all of us. So you'll have 30 minutes health break before you resume your respective rooms where you will do session 4, 5, and 6. That will take us to 12:15 p.m. At 12:15 p.m., again, another panel for that particular within your room to discuss the issues arising from the presentations that have been made, points of clarifications, areas of perhaps considerations going into the future. Thereafter, you go for the lunch break. And when we convene in the afternoon at 2 o'clock, we shall now be basically summarizing and, counting down to the end of the conference by looking at the key lessons, sustainability measures, and the next steps as we have written them down in form of sustainability or transition plans for each of the work streams. So there will be presentations, and we shall have the last panel discussion between 3 and 3:30, and then we conclude by saying what we need to do going into the future, what are our dreams and our hopes as a people, as individual organizations, and then we close, and then we go back to our respective work and trust God to help us to be true to whatever we commit ourselves to. So right now, for these sessions, we shall have the in-service team remaining in this particular room to work under the leadership of the session chair is Scholastica, the in-service, Helen Mutsi and Karen Aura. Could you please stand so that colleagues can see Helen and Karen for the in-service, so that those are the session chairs. So that team will remain here. The pre-service team will go to Chui room, which is on first floor. Chui is just upstairs, first floor, and they will be led by Dr. Lucy Waweru and Dr. Dina Chelangat from Moi University. Professor Dr. Dina, please, and Dr. Waweru, is she here already? I know she was here yesterday. I want to believe she will be coming. So that team, you'll go to Chui, which is just on first floor. And finally, we shall have the MPDSR team. I saw many people signed up for MPDSR, but I think, please don't overcrowd. If you find the room is full, just come and discuss pre-service, because, you know, before we get to MPDSR, we need to be strong on the pre-service and the in-service part of the work. So that team will be led by, the session chair is Scholastica Wabwire. Is Karen, is Scholastica coming? She's around. I haven't seen Scholastica. Okay, fine. So it is confirmed, Scholastica. But if you don't see Scholastica now, there is Martin. Martin, you direct the room, the team. You go to Mount Kenya 2. Mount Kenya 2 is on first floor. So I think that is how we start, because session 1 practically starts at 9:15. So you have 20 minutes to be settled and start and run the session and complete that session. So thank you very much. We will see you over lunch, over tea break, and at lunchtime. Then we convene here again at 2 p.m. Thank you, and see you then. Okay. Okay, so I'm told you are given some small pieces of paper when you are registering. Please confirm where that paper takes you to. And if you are not sure of which room, please talk to me. I will let you know where to go. Mutapewa kila kitu, but you can see, if you have opened it, take it. There is no problem. Yeah. The in-service team, you remain here. In-service, you remain here.
Martin alisema wako na gari yao, tutawadrop. Pending, jioni lazima tuelewe maneno. Unajua Martin ni mtu wa Vihiga, sasa anatetea watu yake sana. Nilimwambia Martin unapenda Vihiga, ni kweli. Tunaona Martin anakava both position na Vihiga, lakini sasa anapenda Vihiga because ni kwao.
Oh, ni kwao.
Si mtu huko. So na mwenje wake naambia wewe unapenda kwenu sana.
So you have to love himself.
Ndio hiyo sasa.
Walisema nilienda.
Jini. Acha niongee na Ndinga. Ndinga hana nini story about this particular campus out. Abisi
Ya love side.
Jina la nini? Ndinga lala.
Ndinga.
Hey man, I will call you.
Mama gari nasimama because mara taaboni hata yeye gari mjini na mpaka tunawaambia hapana. Yo. Hiyo kisha ni joto.
Hii tuko populate sawa.
Hai.
ما يعني واحدة على روتينا every month of 500 they will send you daily. أنا عارف إن عندها مسكين.
لا بهن.
500 شيء. هذا عندي غير هي كم هذا ما في إذا بتشتغل هذا واحد هنا. يا executive welcome you to the new
عايز أعمل معلومات.
There is an exhibition in Sarasota.
Okay, good morning.
Morning.
I think we can move near, please. Kindly move. Kawira, kindly move. Dr. Laura, hope you won't mind if you move here. Na daktari. Florence. Please move near. Okay, good morning.
Good morning.
I'm Helen Mutsi from Division of Reproductive and Maternal Health. Today I'll be your chair and Karen, Karen? Oh, she's on her phone, Okay, so I would like to welcome Dr. Fiona Dixon. Please, before you start your presentation, kindly introduce yourself. Then Dr. Fiona Dixon will be taking us through EMOC functionality assessment, exploring 2 years of data from Vihiga, Uasin Gishu, and Garissa counties. So, Dr. Karibu. (15 to 20 minutes). Kindly stick to that.
apologies for the delay. We're just having one or two technical problems. So good morning, everybody. It's nice to see everybody this morning, and I hope you don't get too bored listening to me because I've got the first two presentations. So as our chair said, my name is Fiona Dickinson. I'm a postdoctoral research associate within the centre in Liverpool. So the first talk that I'm doing this morning is about our EMOC functionality assessment. And this is exploring data from all 5 of the counties that we've been covering during this programme. So to start with, just to talk through the methodology that we used. This was routine monitoring evaluation that we did for the programme. So we started with a baseline for each of the 5 counties over a 3-month period prior to training. So this was to give us a baseline from which to measure. And this was performed at different time points across the 5 different counties. And then following that, we carried out the EMOC training, as I say, at different time points. And then following that, we did monthly follow-up assessments for each of the facilities that were included in the programme. The data was collected for us by members of the facility staff, so members of staff in each of the facilities who'd received training on how to do the data collection using electronic data collection tablets, and then uploaded to a server, a cloud-based server. And then this was then downloaded, cleaned by myself, and then returned to our team here in Kenya for analysis and dissemination to the facilities and to the counties. And I'm sure some of you here might have been involved in that process as well. So just to go over again, for those who are not familiar with them, the signal functions, because that's a large part of what we're going to be talking about. Is it still not on? Okay, maybe we just have to bear with it as it is. So the 7 basic level signal functions cover 3 types of parenteral drugs. So we're talking about antibiotics, we're talking about oxytocin, and we're talking about anticonvulsants, primarily magnesium sulfate. Then there's manual removal of placenta, so for retained placenta following birth. manual vacuum aspiration or removal of retained products, and also assisted vaginal birth, which is in Kenya obviously commonly performed as vacuum extraction. And then also basic neonatal resuscitation with a bag and mask. So those comprise the 7 basic level signal functions that any facility providing childbirth services is expected to be able to perform. The higher level facilities, or the comprehensive level signal functions, include those first 7, plus the ability to perform obstetric surgery, commonly caesarean section, and also to provide blood transfusion. To clarify the difference between availability and performance, these two terms, unfortunately, quite commonly used interchangeably, but for the terms of this evaluation, we were quite clear that availability was where a signal function was available 24/7. So if a woman arrived at the facility any time of day or night, any day of the week, that signal function should be available. So that's what we classed as availability. Sometimes I think other people use the term readiness, but the idea was that whenever the woman arrived at a facility, this should be available. The evidence that we used to decide whether it was available was things like whether there was appropriate staffing, whether there was the necessary drugs, supplies and equipment to actually perform the signal function. In terms of performance, this was slightly different. This was whether the signal function had actually been performed at any point during a month or during a quarter. Okay, and this was based on number of cases reported. So if a facility had 1 case of any of the signal functions, then it was classed as having been performed in that month or that quarter. And so the evidence for this was based on number of cases. Sometimes a signal function could be available but not performed. And also the converse was true as well. So a signal function might have been performed, but it might not be available 24/7. Okay. And as I say, often these terms have in some literature been used interchangeably, but we were quite specific about the difference. So in terms of the results, we had 25 facilities spread across the 5 counties, which you can see on the graph, on the map there. Of these, 24 were owned by the government or the state, and 1 was a private hospital. We had 4 county referral hospitals, 18 sub-county hospitals, and 2 health centres. So that made up the 25 facilities in total. By the end of the study, we had 16 which were designated officially as comprehensive or CMOC facilities. And then we had 11 that were classed as BMOC facilities, so able to offer the basic level signal functions. So you can see the 5 counties that we covered there, which I'm sure by now you're very familiar with. So there was Garissa, Uasin Gishu, Kilifi, Vihiga and Taita Taveta. And as you can see as well from that table at the bottom, hopefully, you can see the range of time that the training took place. This was for pragmatic reasons, because it allowed for training to be carried out consecutively in different places. Obviously, it would have been much more logistically difficult to carry out all of the training in the same in different places at the same time. So the training ranged from June 2019 to February 2020. And because of that, it meant that there were different amounts of data relating to follow-up. So obviously for the earlier facilities, there was more subsequent months of follow-up, whereas for the later facilities, there was less. So looking at the results from the assessment, to describe the facilities, sorry, just bear with us. Okay, so for a facility to be classed as fully functional, all of the signals appropriate for that facility had to be available 24/7. Okay. So for the facilities that were that had the basic, so all of the 25 facilities should have been able to provide the 7 basic level signal functions. So at baseline, we had a total of 14 facilities. That was 6 BMOC and 8 CMOC facilities that were able to provide basic level signal functions 24 hours a day. Following training at Q4, so this is essentially 9 to 12 months after training, that had increased to 19 facilities. So 6 BMOC had become 9 BMOC and 8 CMOC had become 10 CMOC, so which was a notable improvement following the training in terms of the availability. Apologies for this slightly busy chart, but hopefully you'll be able to see. This one looks at the availability again of the signal functions, of the BMOC level signal functions by month. So this is amalgamating all of the month's data that is available for all of the facilities, and the figures are in percent to allow for that. So from the yellow bars, you can see the baseline data, and this covered a total of 75 months of data, 3 months for the 25 facilities. And I think as you can see from that, things like the drugs were actually widely available. So antibiotics and oxytocin were reported as being available everywhere at baseline, which is not, I think, entirely unsurprising. Less so for things like anticonvulsants, and magnesium sulfate wasn't as widely available as oxytocin and antibiotics. And then the red lines show the availability of the different signal functions following training. Okay, so these are the total of follow-up months, and that gives a total of 565 months of data across all facilities for all of the follow-up months. Okay, and as you can see from that, there were actually notable improvements for most of the signal functions. There's a slight drop-off for antibiotics and oxytocin for various reasons, but there's an improvement in the availability of magnesium sulfate and all of the other non-drug related signal functions. So, excuse me, manual removal, MVA, AVB, and neonatal resus all improved in terms of availability following training. So moving to signal function performance, and just to say that we only have data for basic level signal function performance because we don't, as you can see from this is looking at BMOC level signal function performance across all of the facilities. So the orange shows you the CMOC facilities and the green, the BMOC facilities. So at baseline, we had three facilities that were providing all of the basic level signal functions per quarter. We measure performance of signal functions over a quarter rather than a month because some of the less commonly performed signal functions might not be performed in any one month, but they might more likely to be performed over a quarter. So these are measured per quarter. So for the baseline, as I said, there were 3 facilities, all of which were CMOCs, that were able to provide basic level signal functions. And as you can see from the chart, that gradually improved over the course of the year following training. So it's an increase. They actually more than doubled. But I think what's slightly concerning is the fact that not all of the CMOC levels, not all of the comprehensive level facilities were able to provide or were performing all of the basic level signal functions. So for CMOC signal function performance, So this is the basic level signal functions plus caesarean section and blood transfusion. And those, again, doubled between baseline and Q3. So they increased from 23% at baseline to 46% by Q3. The drop-off in Q4 might, we think, have been due to the early stages of the COVID pandemic. But obviously there are various different factors that could have had an impact on these. One of the things that we also asked was about the reasons for non-availability of signal functions. So we asked the facilities to tell us why they didn't or why they didn't perform the different signal functions. So in terms of non-availability, one of the reasons was the lack of drugs, supplies and equipment. So things like magnesium sulfate, which might be less frequently needed, and particularly calcium gluconate, were not always available. In terms of equipment, vacuum extract handheld QEs, again, were the most commonly missing pieces of equipment. And I'll talk more about that in the next presentation. Also things like newborn bag and mask. Obviously these equipment have a limited life. So sometimes they perish and are not necessarily replaced. So looking at reasons for non-performance, by far, as you can see from the chart, the most common reason for non-performance was the number of clients. This was the first option on the list of options for reasons for non-performance. And I think that's possibly why it was the most commonly chosen option. I mean, for some of the smaller facilities, obviously, lack of clients needing a service might well be a valid reason as well. Other things included, to a much lesser extent, lack of drugs, lack of skills on the part of the staff, although that was obviously more common before training than after, and lack of confidence, and then other, and that sometimes covered things like the pandemic. So one of our facilities actually stopped doing any maternity services during the pandemic and was turned over completely to COVID response. Other possible options were staff shortage, national policy, and that the staff were unwilling, but nobody selected any of those. And again, the staff shortage one, it was slightly surprising, bearing in mind the results of the AVB study. Sometimes where a signal function was, where a piece of equipment wasn't available, staff were able to improvise. So that was for things like elbow-length gloves for performing manual removal of placenta. In some instances where these weren't available, staff would use 2 pairs of gloves and just chop the fingers off one pair and you slide it up over. So they'd essentially got a longer pair of gloves. So there were improvisation where necessary. So some of the problems that were encountered, I'm sure, don't think anybody in the room has missed the COVID pandemic, and obviously this had a big impact on services and service provision. As I said already, one of the facilities was turned over completely to pandemic response, and also some of the women, I think, were potentially reluctant to go to the hospital for fear of catching the pandemic, catching the coronavirus whilst there. One of the other big factors that had an impact, we think, was the healthcare workers' strike, the industrial action. So if staff weren't available, then obviously the women were aware of this and just didn't bother going to the facility. And this was noticeable because the private facility actually continued to have good figures in comparison to the government-owned facilities because they were still offering services. One of the other problems that we had, or one of the other challenges that we faced, was staff availability. So staff who were data collectors for us, who were collecting the data, were also working members of staff. They were also providing maternity services. So they were doing this in addition to their normal role. They weren't necessarily given any extra time. So for them, we really appreciate the work that they did for us. But for them, sometimes it was a challenge to go through and collect the necessary data. And then we also have to balance record keeping in terms of clinical versus monitoring and evaluation. Do we collect data for clinical purposes, or do we collect it for monitoring? Okay, and obviously the clinical purposes have to take priority over data collection for monitoring purposes. So it was very much a team effort. We'd like to thank, obviously, the members of the LSTM team who played a very large part in this, particularly Irene, Martin and Onesmus. But obviously other members of the team as well, and particularly, as I've said, the staff in the facilities who collected the data and helped with cleaning it. Yes, a huge vote of appreciation to them. And also acknowledging our partners, both in the counties and national and international level. So thank you. I think we're going to take questions at the end. So. Yes, so well, the technology is being helpful this time. So as I say, I hope you don't get too bored listening to my voice. So this second presentation that I'm doing is looking at a study that we did as a follow-on from the facility evaluation. One of the things that we noticed was that assisted vaginal birth, AVD, was actually the least performed signal function. And the common reason that was given for that was because there were no clients. And in this was even cited in facilities that were having hundreds of births and tens of cesarean sections. So we wanted to look at the reasons why so many facilities were saying that they didn't do it because of lack of clients, and whether there were any other reasons that we could identify, and just what the missed opportunities were in terms of AVB. So we were able to get a little bit of additional funding from LSTM to carry out this study. So I'm talking at this point about second stage cesarean sections and AVB, and Helen will be talking to you a little bit about another part of the study looking at first stage cesarean sections. So again, this was very much another team effort. So, as I say, a little bit of background. So things like unnecessary or incorrectly timed cesarean sections can have huge adverse effects, both short-term and long-term, for the women, for their babies, for their families, and for the wider community. Once a uterus is scarred, it's always scarred. And then obviously that comes with higher risks, with increased risks for subsequent pregnancies. The timely use of AVB can avoid unnecessary second stage cesarean sections. So an AVB, for those who are not clinicians, can only be performed once the cervix is fully dilated. It's what we call second stage of labour. So here we actually looked at a comparison of AVB and second stage cesarean sections. So these are cesarean sections that might potentially have been carried out as an assisted vaginal birth. They can in a lot of situations, or in many situations, expedite delivery. So it's quicker to set up for an assisted vaginal birth than it is commonly for a caesarean section. And also it can be performed in lower level facilities. So midwives can legally perform an assisted vaginal birth, whereas you need a medical doctor to perform a caesarean section, plus somebody to provide anaesthesia. And also there's less risk of mortality, potentially less risk of mortality and morbidity. So either death or long-term illness or long-term disability following an AVB compared to a second stage caesarean section. One of the problems with second stage caesarean section is that the head is already well down in the pelvis, generally speaking. So it means that that head has then, for a caesarean section, got to be pulled back out of the pelvis to be delivered abdominally. Okay, so, and things like that can actually cause more trauma. And as I've already said, our programmatic data, so our data from the programme, highlighted to us the infrequency with which AVB is performed compared to the number of women who are giving birth. So the aim of our study was to describe the indicators for and outcomes of AVB and caesarean section, and to explore the justification, missed opportunities and reasons for these within our study, or within some of our study sites in Kenya. So it was a mixed methods cross-sectional study which consisted of two parts. So the first part was a review of patient case notes. So we aimed to obtain just short of 1,000 sets of records for women who'd had either a caesarean section or an assisted vaginal birth. For various reasons, we weren't able to specify which caesarean section notes we got, so we basically had to pull a large selection and then from those extract the second stage caesarean section notes. On the qualitative side, we also aim to carry out 20 key informant interviews with clinicians and managers at various levels within the facilities to try and understand the whys of what was happening. So the case notes gave us the what, and the interviews gave us the why. So this, as I've already said, this presentation looks primarily at the AVB and second stage caesarean section after full dilatation. So our sampling strategy, we purposefully selected the 8 highest volume facilities from our 25 supported facilities. So these all had more than 130 births per month. As I've already said, the rationale for not performing, or the reasons given for not performing AVB, was commonly that there weren't any clients needing it. So to negate that reason, we picked the facilities with the highest throughput of patients. The facilities selected came from all 5 of our counties, so we got a good geographical spread across the country from all 5 of the counties, which I'm sure by now you're very familiar with. The time frame that we chose was between June and November 2020. Again, this was deliberately selected to provide a time frame or a window of time between the highest impact of the COVID at the very beginning and the healthcare workers' strikes. So we wanted this window of opportunity with hopefully the least impact from COVID and healthcare workers' strikes. To talk about the births, the mean range of births for the facilities was between 135 and 411 births per month. In terms of the case notes that we reviewed, there we go, one more. So as I say, we randomly selected the caesarean sections. So for facilities where we had a sampling frame, where we had the numbers of the case notes, we were able to just select the case notes. So for some facilities, we could look on KHIS, select the facilities and say, okay, we would like you to send us these case notes, please. Where that wasn't possible, we asked facilities to select every third or fourth caesarean section from the registers, pull those notes and send those. Okay. In terms of the process, the notes were copied within the facilities. So the case notes were pulled quite often by the health records officers and photocopied and sent to Nairobi to Pamela's office in the Secretariat. They were scanned and then anonymised electronically. So they were redacted, the identifiable information was taken out electronically. And then a study number was allocated to each set of case notes. In terms of the methods, our aim was we had a team of clinical experts, both from the UK and from Kenya. And they were asked to go through the case records and identify those which they thought a caesarean section was necessary and appropriate, those where it was not possible to determine whether it was appropriate and necessary, either because of lack of information or because of a delay in performing the caesarean section. So it was felt that if there was a significant delay between the decision to perform C-section and it actually being performed without any additional examination of the woman, circumstances could have changed within that time, meaning that the AVB might have become more appropriate. And then the final category was that they felt that AVB should have been attempted. Obviously, with hindsight, there's no way we can say what the outcome of that would, but it was felt that they should at least have been attempted. And then for our key informant interviews, so we had a purposive sampling of between 2 and 4 participants per facility. And again, we were looking at people who were either nurses, doctors, or a few hospital management, people who were in hospital management, but who were either expected to be carrying out either assisted vaginal births or caesarean sections or making decisions about the management of these cases. Initial contact was by our technical officers who already had existing relationships with the staff in the facilities, so they were able to approach them and ask them if they'd be willing to take part. And then the paperwork, this consent process was done electronically, again, because this was carried out against a backdrop of COVID. The interviews were carried out on Zoom and recorded with consent by Helen and myself, and we used a semi-structured topic guide to guide the interviews. So just a brief overview of the results that we found from this study. We were able to obtain 67 cases of second stage caesarean section and 6 cases of AVB. We think there were more cases of AVB, but these were the only ones that the records officers were able to actually lay hands on the notes. And then, as I said, we had 20 key informant interviews, of which 9 were nurses, 5 were medical officers, and 6 were consultant obstetricians. In terms of data from the facility assessments, overall 0.31% of births were carried out by assisted vaginal birth. Okay, so this is a lot lower than many high-income countries, and actually lower than even some other sub-Saharan African countries. And 3 out of the 8 facilities didn't perform any AVB at all. And again, this is all facilities where they had in excess of 130 births per month. And again, lack of clients was the most common reason, despite having over 780 births over the 6-month period. So out of over 780 births, facilities were saying they didn't have a single case where AVB might have been appropriate. In terms of the overall findings, there were various factors commonly interrelated, which were given as reasons for non-performance. So in terms of the case note review, so you can see from this, a third of the cases, it was felt that caesarean section was necessary and appropriate for various reasons. For over half of the cases, it wasn't possible to determine the appropriateness of the caesarean section because of either lack of information, contradictory information within the notes, or because of a delay in actually performing the procedure, during which time circumstances could have changed. So in only 10% of the cases, AVB was felt to be appropriate. But again, this is 10% which could have been avoiding having to have an abdominal scar and with the associated risks with that. As I've already said, sometimes the notes were contradictory, so cervical dilatation was written, was different in different places within the notes. So one person might say it was, I don't know, 8 centimetres, and somebody else might say it was fully, even at the same time, or even fully prior and then reverting to 8 centimetres after. There were significant delays in some cases of up to 5 hours from the decision to perform a caesarean section to it actually happening. In terms of maternal outcomes, there were no maternal deaths, fortunately, but there were 5 cases of postpartum hemorrhage. For perinatal outcomes, there were 13 cases where there were complications for the baby. We had a look to see whether this was associated with birth weight, but there was no association between adverse outcomes and birth weight. The birth weights ranged between 1.7 and 4.4 kilos. And as you can see from the pie chart there, there were 2 neonatal deaths. There were 4 stillbirths, and then there were a further 7 cases of other complications, either convulsions, signs of birth asphyxia, or admission to the neonatal unit. In contrast, the findings from the AVB cases, we had a total of 6 cases, as I've said, and there were no maternal or perinatal deaths at all in these 6 cases. Obviously, this is a much smaller sample size, but as I say, there were no deaths recorded. Of the 6, 4 had good outcomes. They had APGAR scores of 9 or 10 at 5 minutes. So this is an indication that the babies had been delivered in good condition. There were 2 cases of poor outcomes, so 2 cases of signs of birth asphyxia, but these were both situations where the woman had been referred in from a facility more than half an hour away. Okay, so this woman had been and had arrived fully dilated. We're not able to say, because there's no information about whether she was fully dilated when she left the referring facility, but obviously she must have been close to that to have arrived at full dilatation. Okay. And of these 2 women, one of the mothers had a PPH, a postpartum hemorrhage. So from the interviews, one of the questions we asked was, what did the clinicians think the women's understanding of AVB was? Would they be willing to accept it? And this one midwife said she thought that the majority of the women didn't understand what AVB was. So maybe there's a need for better antenatal education. Another medical officer said in this community, the ones who want to give birth to 15 children, they want to avoid caesarean section as much as possible because they know that it's going to limit the number of children they're going to get. Okay, so the doctor thought that women would be willing to have AVB if it meant avoiding having an unnecessary abdominal scar and obviously limiting then the number of subsequent pregnancies. One of the issues that we'd come across, particularly during the interviews, was this issue of the most of the clinicians preferred the handheld Kiwi devices. So it's a little handheld suction cup to do assisted vaginal births, as opposed to the big foot pump or hand pump, which is a 2-person job. Okay, so most people preferred little handheld devices. One of the problems with handheld devices is that they are designed to be single use. They're designed to be used once and thrown away. Obviously, in situations where resources are scarce, facilities didn't generally do this. The devices were cleaned, sterilised and reused. Because of that, after so many uses, they failed to work properly. So you might have the device, but it wouldn't generate the vacuum properly. Okay. And this is summed up again by this medical officer who said they are washed and stored but are not discarded because we're a poor setting whereby you can't afford to just discard it. If it is something that can be sterilised and packaged again, we would rather do that. Okay. As I said in the previous one, there were no references to staffing being a reason for non-performance of signal functions. And yet, this obstetrician said that at times we only have 2 nurses covering maternity. By maternity, I mean the 2 nurses are in charge of the antenatal, they're in charge of the labour, and they are in charge of postnatal. So obviously, and almost everybody that we spoke to said that lack of staffing was an issue. There were also issues of confidence and competence. So not all of these interviewees had had the EMOC training, but most of them had. One midwife said some of them have been trained and others not, but what is lacking in most of them is just confidence. So although they might have had the training, they might not have felt confident enough to be able to perform the procedure, either through lack of support or lack of ongoing refresher training. And one of the medical officers said, you train this medical officer or this nurse or this midwife, but after training them, they become experienced and then they're moved and taken away from that department. And again, this was another theme that came up repeatedly, the staff being rotated to non-maternity departments where their skills would not be used and would diminish. And I think this tries to highlight in a 2-dimensional way what is quite a 3-dimensional issue in terms of the interconnectedness of the different issues that we found. So lack of equipment would mean that it's difficult to do on-site training. If you haven't got the equipment, it's difficult to do the proper training. If you haven't got the equipment, then you can't use it, which means that your confidence and competence are going to decline. Lack of staffing means that you haven't got staff capacity to be able to send somebody away for training, and also you've not necessarily got the staff to support each other to put into practice what they've learnt. Things like beliefs, if you don't believe that you can do it, that's going to impact your confidence and competence. But conversely, if you have necessary training, then that can increase your confidence, increase your belief in yourself. Okay, so there are a whole raft of interconnected issues. So just to summarise, there were multiple barriers evident to the use of AVB. It wasn't just as simple as lack of clients needing the signal function. The AVB outcomes that were encountered, poor outcomes, were probably due or potentially due to a delay in the procedure being performed. If it had been performed in the referring facility rather than in the receiving facility, then they might have had better outcomes. And the flip side to that as well is that if the woman had been referred and then had a caesarean section, that could have incurred an even greater delay and even worse outcomes. There is a real need to improve record keeping, and I'm sure Helen will talk about this more in a minute. For various different reasons. And then training and future interventions need to be comprehensive and they need to be sustainable. It's not enough to just do a training and then walk away. There's that need for ongoing mentorship and support within facilities, for facility staff to support and encourage each other, the need for senior leadership within facilities to support more junior or less experienced colleagues to actually perform these procedures. And without these, then the more junior staff are always going to struggle. And in terms of the barriers, I think it can be considered at almost like an onion, different layers. So at a national or county level, you've got the issues of staffing and basic training. A lot of the people said that the lack of basic training for things like AVB, even for the doctors, was an issue, and there's only so much you can do in a one-week training. Okay, so there needs to be, and as I'm sure, if you're in the, hopefully you'll be able to catch up on the pre-service training session afterwards, that is now being addressed. Lack of facility, lack of equipment at facility level, and lack of on-the-job training and leadership at facility level. And then also, at the personal level, a lack of confidence to practice. Okay. So again, very much a team effort. We'd like to thank our colleagues and all the other people who took part, the clinicians who gave their time to do the interviews. And then, yeah. So thank you. And yeah, we'll look forward to questions at the end.
Kindly just keep your questions so that we do them together. Karibu, Helen.
Irene, you're going to fix the slides for me. Shall we have an energizer? I really liked the one we did yesterday when we reached up to the mortality and reached down to bring it down. Can everybody stand up, put your phones down? I don't want to see any phones in hands during this talk, please. So let's reach up to maternal mortality, reach right down to bring it right down to below 70, reach up to newborn mortality, reach down to bring it right down to less than 12 per 1,000, and we'll make the SDGs. Thank you. Everybody sit down. So, okay, we ready? So most of you know who I am, but in case we haven't met, my name's Helen. I'm an obstetrician. I worked clinically for 36 years. Mostly in the National Health Service in the UK, but quite a bit of the time in Uganda as well. And then I joined LSTM in 2016, and I've been there since then. So I'm getting on a bit. Okay, we're just hoping these slides are going to start in a minute. Okay, so just while we're waiting, what I'm going to talk to you about, the title is Too Much Too Soon, ? And I'm sure you're all aware of some very famous papers that were published in the past on the subject of too little too late or too much too soon. And too much too soon relates really to us being over keen to make medical interventions, and we want to be able to not intervene unnecessarily and to give women the opportunity as much as is possible to be able to achieve a normal birth. Is this not going to work? This? Okay, sorry. So I just want to, while we're waiting, I don't want to waste, in the interest of not wasting time, I'd just like to see if I can. No. It's just stuck, sorry. Somebody's coming now to help. I suppose I should declare my personal side of things as well as being an obstetrician. I'm a mum. I'm actually a grandma now as well, but I had 3 children, and I was very happy that when the first child was born, I had a normal birth, looked after by excellent midwives. And after that, I really wanted to continue to have normal births. And I did, in the end, have 3 children and 3 normal vaginal births. And I so appreciated that. it was great to be able to go home and look after my children without getting over major surgery. That's not to say caesarean section isn't necessary sometimes. It really is. It life saves both women and babies on occasion. But there are times when it might be better not to do too much too soon. So in terms of, we can see the slides now. In terms of the talk, we're looking at background and rationale, the methodology of the study, the results, and the discussion and some suggested next steps. So the background, we know that caesareans are rising globally. There isn't a country in the world where the caesarean section rate hasn't gone up. I can remember as a resident myself producing the annual report for our hospital several years running, and I remember being shocked when caesarean sections reached about 12%. Now in the UK they're above 25%, but they're going up in Kenya as well. The most common surgical procedure performed worldwide is caesarean section, and more than 1 in 5 babies globally are now born by caesarean. And yet, we know there is a disproportionate maternal loss in lower and middle income countries, including Kenya, in association with caesarean birth. And we've seen that from the confidential inquiry here. We know that of the women who give birth by caesarean section, a greater proportion of them die than of the women who give birth by other means. Now, it's not always because of the caesarean section, but there is a strong association. And it's not just death. There is a significant risk of both short and long-term complications with caesarean section. So in the short term, more risk of hemorrhage and infection postpartum. In the long term, there is 2 big risks. We all think a lot about the risk of ruptured uterus. Perhaps we don't think as much as we should about the risk of abnormal placentation and placenta accreta in subsequent pregnancies. And if you've ever had to operate on somebody with a placenta accreta, you will realize how very difficult it is to save a life in that situation. And yet, despite all this, the decisions to perform caesarean sections are often made by doctors who are not specialists and who lack experience but lack support to make that decision. You know, there's 2 aspects of doing anything in midwifery and obstetrics. There's the doing of the skill. And we're often very focused on learning skills in all our training. You know, how to do a breech, how to do a shoulder dystocia, how to do this, that, and the other. What we need to focus on as well is how to make the right decision to do the skill that we need to do. And if we don't make the right decision, then we can be as good as we like at the skill. We're still not doing the right thing. So the rationale for this was that even when caesarean section rates are relatively low still, not all the caesareans are necessarily appropriate. So the fact you've got a lower rate doesn't mean that all the caesareans need to be done necessarily. Caesareans are costly, both to the health system and to the patients. And when we do a caesarean that might not be necessary, reduce the capacity of that facility to then perform another caesarean that might well be necessary, but in a timely fashion. Therefore, we need to make sure that we're doing the caesareans for the right reasons, for the right women, and at the best time. And that's what quality of care is about. So we wanted to analyze some case records, and this follows on from the study that Fiona's just presented. It was using the same case series, but this time we were selecting first stage caesarean sections. So caesareans done in established labor, but before full dilation. So with those women, there wasn't the option of an assisted vaginal birth. But nevertheless, we wanted to see if these caesareans might have been avoidable. So we selected 87 cases. We initially selected 90, but 3 turned out not to be in the first stage of labor, so were rejected. Again, from 7 referral hospitals over our 3 counties over a 6-month period, exactly as Fiona described to you. And again, the notes were reviewed by a panel of experts from the UK and Kenya. So I was the UK expert, and I reviewed all the cases, and then the Kenyan experts, we split between them, so everybody reviewed a certain proportion. And what did we look for? So the data we extracted was We wanted to know, were the cases referrals or were they admitted directly to that particular facility from home? We wanted to know about their parity and their previous cesarean history. How many babies were on board? Was it singleton, multiple pregnancy? What was the presentation, cephalic, breech, transverse, birth weight and APGAR scores, outcomes and complications for both mothers and babies? What was the stated reason for the cesarean? What was the dilation of the cervix, the descent of the presenting part, the position of the presenting part, and the contraction frequency at decision? And this is where a lot of the data was not recorded in the records. What was the decision to delivery interval that Fiona's already alluded to as being long sometimes? And then the reviewers scored the appropriateness or not, and I'll explain that to you in a minute, and made comments. And then we had discussions between ourselves and agreed on what we thought. So the review process was that all the notes were first of all reviewed independently by both myself and one of the Kenyan experts. We then compared our reviews. If we didn't agree, we discussed and tried to reach agreement. And where there were outstanding cases where we couldn't agree, then the whole panel met to discuss and contextualize as well. So in terms of the categories, we had 6 categories this time, a bit more than with the AVB. So the first was that the cesarean was considered to be both necessary and appropriate. The second was that the cesarean was done too soon, and perhaps something else could have been done to manage the labor. You know, maybe with a primip, augmentation could have happened with oxytocin to try to help the labor progress and maybe avoid surgery, but that wasn't done. The third category was that, well, there was a decision made, but the delivery interval was very long, and the woman should probably be examined again to see if something had changed during that interval. And had that change happened, the cesarean might have been avoidable. The fourth category was a bit allied to the first category in that the cesarean was necessary, but it was done too late. In our judgment, it should have been done more quickly. The fifth category was that the medical records lacked the necessary information for us to make a judgment about appropriateness. And the sixth category was that we felt that the cesarean was not appropriate at all. So this is the overall results. So you can see the 33% we felt were appropriate, and so that's the, if I can point to it, yeah. So those were the appropriate ones, and those were the ones that were appropriate but not done soon enough. So that comes to about 41% altogether we considered were needed a cesarean section, but the rest may not have done. So we found that we thought 9% were in the done too soon category, where alternative measures may have been suitable. The should have been reassessed group because of the delay was 10%. The not appropriate was 12%. And 22% was the records were of poor quality and we couldn't decide. And there's 6% where we didn't reach an agreement amongst ourselves. So, and really looking at the referrals and the non-referrals, it didn't really make much difference at all in terms of the appropriateness or otherwise. So in terms of the referrals, you can see 42% we felt it was appropriate, including 10% that were done too late. With the non-referrals, 41%, including 7% that were done too late. So not much difference, really, whether the patients were referred or not. In terms of the missing data, and this is data that you should take into account when you make a decision. So particularly the abdominal descent of the presenting part, the position of the presenting part, and the contraction frequency were very poorly recorded in the records. Other things were also not recorded, but to a lesser extent. But if you don't record all the right things about making your decision that you need to make your decision, perhaps you didn't take them into account when you made your decision. So in terms of adverse outcomes, we had 3 PPHs in this group. One mother developed a bad chest infection and one mother had a bladder injury from the surgery. For the babies, there were 2 fresh stillbirths. And this is a fresh stillbirth, is a baby that's died in labour. 6 babies were admitted to the newborn care units, and 6 babies had persisting low APGAR scores. And that included 2 babies who had 5-minute APGAR scores of 3. Now, that is a child who is not going to do well. If those children survive, they will most probably go on to develop complications, perhaps newborn, ischemic encephalopathy and subsequent cerebral palsy. And this really matters. Bringing up a child with cerebral palsy is a long-term stress to families, family breakdown, and all sorts of bad things happen. It's almost, you might even say in some cases worse than losing a baby, to have a child that you have to bring up who's severely disabled. And we can avoid that with better care in many cases. 1 baby had sepsis. So this is looking at the decision to delivery interval. So the number of hours is along the bottom. And you can see that the majority of cases, that decision to deliver interval was 2 hours or more, sometimes more than 4 hours. This is looking at the reason stated, done for non-reassuring fetal status. In other words, the operator was worried about the baby's condition. Now, if you're worried about the baby's condition, would you not want to do the cesarean section more quickly? And yet, we can see the blue bars, still the vast majority, were 2 hours or more. Of course, people are not always right about non-reassuring fetal status. Sometimes they misinterpret what's going on with the baby. But we can see the orange bars are the cases where those babies had a particularly poor outcome. And 5 of the 8 babies in that category were more than 2 hours from the decision to the delivery. So that's not appropriate, really. If we're worried about the babies, then we need to be able to get them out quickly. So, in terms of discussion, the delivery, decision to delivery interval was generally suboptimal. There was a lack of fetal monitoring. In virtually all the labours were not monitored. The fetal monitoring was not done according to either Kenyan or international guidelines in terms of not listening to the baby's heart half-hourly in the first stage. And once the decision was made, it was as if, oh, well, that's her out of our hair, we can stop monitoring now. So neither mothers nor babies were monitored, even with those very long decision delivery intervals. Some of the women were sent to theatre, and the delays occurred waiting to get into the operating room in the theatre complex. Some of them were delayed on the labour ward, but regardless, they weren't being monitored. And if you're waiting more than 4 hours, it really matters that your baby should be listened to in that time. There was an issue about meconium liquor, and this was where we couldn't come to an agreement, because most guidelines, and I've checked, the Kenyan guidelines included, say that if you've got meconium in the liquor, the first thing you should do is to enhance your fetal monitoring. But in many cases, the meconium in the liquor just translates into just do a section. Okay, thank you, 5 minutes. And that results in unnecessary sections. I'm sure those of you who are midwives in the room, hands up if you've ever delivered a baby that's covered in meconium and comes out screaming. Yep, quite a few of you have, okay. Meconium doesn't, in the majority of cases, mean severe fetal distress. So what we should do with meconium is enhance our monitoring. But there is this attitude of defensive obstetric practice. You're kind of, if you've done a cesarean, well, you've been seen to have done everything you could and nobody will blame you. But maybe several years down the road when the mother has her placenta accreta and you've started the ball rolling by an unnecessary cesarean, perhaps there is an issue there. We have a real problem with the poor quality of medical records. We often found there was no partograph available for review. I don't know if it's because the partograph wasn't done or because they're kept somewhere else, but it didn't make our task easier. But what was written in the notes that we could see was insufficient in many cases for appropriate decision making, and I think many unnecessary cesareans were performed. So we wondered what was the sort of issue, and we looked at midwifery caseload. So you can look at caseload in terms of, you know, how many midwife full-time equivalent do you have in an establishment, and how many births per year are there, and what's therefore the midwifery annual caseload. So we looked at that for the 7 facilities. Just by means of comparison, the recommended annual midwifery caseload in the United Kingdom is 36 women per year. And you can see that here in Kenya, you're obliged to, the midwives have to do far more deliveries, look after far more women a year than that. So even in facilities where it's lower, it's still very high. But interestingly, it was in your facilities that had the lower caseload burden for midwives that had the higher caesarean section rate. So it wasn't because those midwives were extra sort of pressured that more caesareans happened. It was perhaps the opposite. So I don't know, there must be other reasons for that, but I was beyond the remit of this study to determine that. But it was an interesting thing to look at. So in terms of what we recommend on the basis of these results, I think the first thing is to improve fetal monitoring in labour, including after a decision to do the caesarean has been made. Because if you subsequently find that fetal distress develops or becomes more severe, then you would need to, you know, bring the caesarean forward. Improve clinical examinations and do a comprehensive examination, including all the factors that need to be taken into consideration when you do a caesarean section. Certainly improve decision to delivery intervals, and part of the way to do that is to avoid the unnecessary sections that clutter up the theatre and delay the more necessary sections. Re-examine women if there is a delay to see if their labour has progressed in the meantime, and maybe the decision can be re-evaluated. Improve record keeping and the quality of record keeping, and provide support for inexperienced doctors when it comes to decision making. Medical officers are not specialists, and they need support to make these complicated decisions. And the WHO recommends that every caesarean should be decided upon by 2 clinicians, not 1, because of the high stakes in doing caesareans. So in terms of next steps, what we'd like to do, if we had funding, would be some targeted training about fetal monitoring, really helping both midwives and doctors to understand the meaning of the fetal heart in labour, what it's telling us and how to interpret it, and why it's so important to do. You know, we're amongst the very few physicians who've got to look after 2 patients at once as midwives and obstetricians, and sometimes clinical officers. We look after the mother and the baby together, and that's a unique responsibility, so we need to know how to do that well. We need to think about proper examinations, taking in all those things into account, good decision making and record keeping, so more targeted training on those issues. Introduce regular decision to delivery interval audits in our facilities with targets that we can, standards-based audit that we can see how we perform. Consider the introduction of a decision-making checklist so that we don't miss important factors in the decisions, and then conduct a larger study, I think. So thank you very much to Pamela and the record gathering team in Kenya, Fiona, and the Kenyan doctors, experts who were part of our review team, without who the study couldn't have happened. Thank you very much to everyone, and acknowledgements to our partners and donors. So there we are. Thank you very much.
Thank you, Helen. I wish you to sit in front here. Fiona, kindly. So thank you very much for wonderful presentation, Helen. And I know there are more reactions than questions. Maybe it is for me. For the rest of the team, I don't know. Mine is more of addition than questions. So we'll take questions and kindly note them down so that we take maybe 5 questions per 1 round. So anyone who has a question for Helen, and I think we start with Fiona's. Thank you.
So thank you very much. My name is Peter. I was part of a friend to LSTM, basically. We really worked together on working on some of these tools. I have a question for Fiona. And that question is based on the findings you had, especially in slide number 11, the issues about assessment, whether it was availability of EMOC, availability or performance. I think that's what I really wanted to know. And I was actually very much curious about the availability of clients, where over 90% people mentioned that availability of clients was an issue. Was there a particular signal function, or maybe was it overall signal functions where they mentioned lack of clients, or was it maybe one particular signal function which really mentioned lack of clients? Thank you very much. I think the next question I'll ask for Helen later, as you just mentioned.
Thank you, Peter. Anyone else with a question?
Good morning, and thank you for the presentation. My name is Abigail from Vihiga County. My question is about the functionality assessment, and specifically on issues of supplies and the issue of magnesium sulfate. And probably I think it could give us more information. Majorly in our facilities, you find that you ask someone, you're referring without giving maybe the pre-medication. The reason is the issue of the fear of the side effects. The fear is not that is what comes out majorly. So the issue is, was the magnesium sulfate available, or there were cases and it was not administered, or what was the main issue? Thank you.
Thank you. Toxicity, I think that will be the question. Anyone else?
Okay, so mine maybe it's a comment, and maybe not for Fiona and whatever to answer, but maybe the people from the ministry can support us in trying to just unpack it. You know, from the findings, when it comes to BMOC, CMOC, we want to say, is it available, is it being performed? And on the other side, as a country, we keep saying that, you know, our coverage for BMOC is so much, 50%, 30%. So I don't know the connection between what has been presented and maybe what the health facility assessment report said. You know, there was a very nice figure there that, you know, most of our facilities can do BMOC, but we can obviously see that of the 7 signal function, even in those 25 facilities that were assessed, very few are doing it, and yet the facilities were said to be BMOC compliant. So everybody thinks that, you know, all the signal functions, most likely the supplies are there, the staff are competent. Secondly, and I think what is being flagged out is the issue of assisted vaginal births. My question is it that the workers have just refused to do it? What is the national guidance? And what are we really going to do about it? Because to me, it is a subject matter that seems not very exciting, not being implemented for reasons that are beyond me. Okay, thank you.
Good morning, everyone. My name is Patrick Ingori from Jacaranda Health. I was not with you yesterday. My first question is on the EMOC functionality. One thing we observe is that about 0.31 of birds are by AVB, whereas in the review of cases is about 10% should have been AVB appropriate. Although the healthcare workers are reporting that lack of client in a number of about 7 and 8 birds, could there have some in-depth interviews with the healthcare workers that could show that there is a gap in the skill? And as much as we've noted that there is lack of the AVB kits in the health facilities, again, could be the lack of AVB kits worsening the fact that there's no deliveries or the drills in those facilities, or even return demonstration in those facilities, and therefore even healthcare workers who have already been trained are losing their skill over time. My second question will be on the too much too soon part. whereby, again, we see workload versus CS rate. It is high in facilities that we would expect it to be lower, where healthcare workers, where nurses have a high, in facilities with a high caseload, there are fewer cases of CSs, as against the facilities with lower caseload, where we'd expect maybe this nurse has adequate time to observe these mothers and make appropriate decision. Again, could that be a question of the skills gap, in that we know naturally we tend to pick nurses to go for trainings from the high volume facilities, and maybe somehow we would have left out nurses in the lower volume facilities that also again would need the skill. Do we have some numbers that indicate what is the ratio of EMOC trained versus the non-EMOC trained nurses?
Thank you, everyone.
So I'll try and address the questions in order. So in terms of availability versus performance, and the lack of clients was across the board. For all of the signal functions were reporting that, that lack of clients was the reason for non-performance. We did think about it and wondered whether it might have been almost the easy option in terms of answers, because it was the one that enabled staff, facilities to save face. You know, if there was no clients needing it, then it wasn't their fault. If they admitted that there was lack of staff, that the staff weren't trained, that the staff weren't confident, then there was then a degree of responsibility. But obviously, this was routine M&E monitoring, so in that respect, we weren't able to sort of dig down into the sort of the deeper understanding of exactly why. But yeah, it was across the board. In terms of magnesium sulfate, sorry, let me put my glasses on. So magnesium sulfate, I think it was because it was a less commonly used drug compared to things like antibiotics and oxytocin, which is obviously used. So antibiotics are used throughout the facility, so those were more commonly available. Oxytocin is used for pretty much every birth, so again that was commonly available. Magnesium sulfate, as I said, was less commonly used, and therefore was less. That potentially is likely to be the reason why it was less commonly available. But yeah, I mean, in terms of referrals, why it wasn't given before referrals, I don't know. That's not something that we looked at in any real detail. In terms of why they didn't do AVB, I mean, I think if you look at the statistics as well, if you take out the two categories where we were unable to determine because of either lack of information or because of delay, that means that you're left with 30%, just over 30%, who were, for whom C-section was appropriate, versus the 10%. So you could argue that actually where we were able to determine the outcome, the appropriateness, a quarter of women could conceivably have had an AVB, which obviously then makes it a much higher proportion. Why they don't do them? I think there are a whole raft of reasons, some of which came out in the interviews. For some, they were very much in favour of AVBs being performed and being available. One doctor who we asked, he said, yes, I think AVB is a good idea. But one of the other questions that we asked was, would you allow your wife, or if it was a female respondent, would you have an AVB? And this one doctor said, if it was my wife now, I wouldn't let it get to that stage, I would do C-section. Which I think was quite telling in terms of, yes, it's okay and it's good in theory, but actually there was almost a security blanket of caesarean section. It gave them more of a sense of control. One of the other unfortunate comments which we had from a medical officer about another medical officer was that because the staff are rotated, one of his colleagues actually was much more interested in the surgical rotation, and therefore when he got sent to obstetrics, he would do C-section because it gave him a chance to practice his surgical skills. I mean, obviously these are sort of outlying comments. You know, they weren't the norm, but it does give you a flavour of some of the sort of thinking that, yes, in theory, AVB is great, but actually there were personal reasons for some people why they didn't want to do it. I think there's also a lack of confidence, and so the lack of basic training in doing AVB, I think, was an issue. A 1-week course where you might get maximum of 2 hours on how to do AVB. If you've never had that basic underpinning training to start with, the 2 hours isn't going to be enough to make you a competent, confident practitioner. And without that support going back into the facility, if your senior colleagues in the facility are not confident and competent, then you're very quickly going to lose any confidence and competence that you have gained if you haven't got that support there. So there is that need for that critical mass within facilities. You know, if your senior says, yeah, well, you might have learned that on the course, but actually I don't like the idea, therefore you're not doing it in my facility. What can they do? So, yeah.
Thank you. Just by way of encouragement, we spent a little while in Garissa a few months ago. We had the KML in Garissa, and after which we did some mentorship in Garissa Hospital, in the regional referral hospital, and we had mentors from the various sub-county hospitals present, and we really focused on AVB training in a sort of intense way with those mentors. Since then, we've had some really encouraging reports from some of those sub-county hospitals that those mentors have gone back and have had the courage to start doing assisted vaginal births. And I mean, it's a really big deal in a woman in Garissa County to be referred in the second stage. The distances are vast, the roads aren't great, it's horrible. I mean, those of you who've had a baby, you'll remember when you're in the second stage of labor, you feel like you're about to die, don't you? It's awful. And to think of being put in a vehicle and bumped along a dirt road for 100 kilometers in that, it's not good. So, I mean, the fact that these mentors have had the courage to start now doing AVBs in those distant sub-county hospitals and to train their mentees to do it too now really encourages me that change can happen and that we can avoid these second stage caesarean sections often. And, you know, the study that Sobey et al. Published in The Lancet said that the deaths associated with second stage caesarean section, I think it was 12 times as much as the first stage. It was massively more dangerous to have a caesarean in the second stage of labor than in other times. So it really makes a difference to try and avoid them. I think just on top of those things, I think we've proved from our study that the facility assessments saying that there were nobody needing assisted vaginal births just wasn't true. We've shown that there were. It was just people weren't acknowledging that. And again, the assessments sometimes said equipment was missing, but our interviews showed that sometimes the equipment was there, but people didn't have the confidence to use it. In terms of the question about midwifery caseload, I don't think that the midwifery caseload is good anywhere. I mean, you know, compared to international standards, the midwives here have much more work to do, even in the quieter facilities. So I don't think we can say, oh, it's okay in some places and not in others. I don't think it's ever okay, really. And I'm sure those of you who are practicing midwives would bear that out, that you're very, very busy and maybe don't usually, I mean, you'll have quiet days, but on your average day, there probably isn't enough time to devote to your clients as much as you would wish. But yes, you're right, there is an element of anxiety, and I think that can be overcome with better training and better mentorship support. And I just think mentorship is so, and we'll talk about this later on this morning, it's so important to have good mentorship following on from training. Otherwise, you don't reap the benefits to nearly that extent that you should. But also, there's the issue of staff rotation that was addressed yesterday. You know, you can train staff, you can mentor them, they become confident and competent, and then they get rotated to ophthalmology. And what's the point of that? You know, we need experts who are keen practitioners, who love midwifery and love obstetrics, to stay in that field. I think any labour ward benefits from having staff who are, you know, really experienced and really skilled there in the long term, and I think that can vastly improve the quality of midwifery and obstetric care.
Thank you, Helen. Anyone who has a burning question? Probably I want to speak about most facilities, Bimong Simong. I think, Dr. you asked about that, sorry. Yeah, we're almost closing because we need to go to other sessions. Some questions will be asked still in another session. So I want to comment about the facilities. Remember during devolution, did anything change? What happened? Facilities were just elevated and nothing changed. So if you are a facility, you've been elevated, you do not have operating theater, what happens to your clients? You're supposed to be referred, but you are a which facility? You are supposed to be operating clients in your facility. It was elevated, but you do not have that facility. What happens to the clients? And then the politicians who don't want to be referred, these clients are supposed to be operated in their facility. And remember, there is no theater in that facility. Who has failed? We blame who now? As clinicians. Do you blame anybody? We need to offer quality of care. What do we do? Because the facility is supposed to be operating and there's no theater, has an infrastructure. What happens? Hello? You refer, but the facility remains a what? A level 4. But it's not a simple facility. What do we do?
If it is a level 4 facility, it is us to ensure that we advocate for what is expected and let it to the leaders. We need to have a functional theater. This is what is expected, so that to ensure that this facility operates as level 4. If not, it should go back to level 3.
Thank you. Let it go back to where it belongs, and we do the right thing. We advocate for good services at all levels. And then for me, the summary of all these sessions is about monitoring of our clients using a pantograph. Healthcare providers really monitor these clients. Some of them monitor very well, chatting on a pantograph, but they cannot interpret what they have chatted. Isn't it true? They have chatted. They saw even here I could have taken action because there was a problem with fetal heart. But I never took action. I continued chatting. I do not know how to interpret this pantograph for action to be taken. So we need to do continuous mentorship when it comes to pantograph, because pantograph is a tool that is going to inform us on when to intervene when we are having an issue with a client. When it comes to magnesium sulfate, I know the problem is not about magnesium sulfate missing or not missing. It is about toxicity. Healthcare providers fear giving it, and sometimes they do not have an antidote. So what do? A woman continue convulsing, they are not giving, and they are not referring. So we need to mentor nurses on how to do dilution when it comes to magnesium sulfate, and what do you do in case there is toxicity, and how do you even monitor for toxicity during the provision of magnesium sulfate. And then oxytocin. We did a study on oxytocin. We picked many oxytocins in many facilities. What did we find? Tunapeana juice. So this patient continue bleeding, continue pumping this oxytocin up to 80 milligrams, and there is no change. And we are not taking action. We are not referring this woman. So what do? The potency get lost. You get somebody alichukua ice pack, akatoa nje ya cooler box, akasimamisha oxytocin, the whole day iko pale juu. What has happened to the potency? It is not maintained. So what are we giving at the end of the day? Juice. So what is our game changer? What is our game changer? Somebody is talking about carbetocin. Anyway, carbetocin will come to help us in many ways, especially in the counties where temperatures are haywire, but still we need to maintain the potency of this oxytocin. So any burning question, because we are going for tea and then we come in with a different session?
Thank you, and thank you for the wonderful presentations. Just one comment. I don't know whether you came across unsupervised medical students in the ward and what was their contribution towards patient care. And for the oxytocin, when will the division take into consideration how the immunization program takes care of their cold chain, and also look at sort of having such stringent measures on medicines that need cold chain for effective potency? So to the two panelists and supervised students, what was your take and what was your experience? Then to Karen, cold chain, we can learn from the immunization program.
Thank you, Dr. Laura.
I didn't come across any issues about medical students, but I would say that medical students should not ever be unsupervised. They are not qualified, neither are student midwives. They should not be managing the care of patients without immediate supervision. That's not ethical, and it shouldn't happen. I wouldn't want my daughter to have a cesarean section performed by a medical student who wasn't qualified. I don't think any of us would. And, you know, that just should be a no-no, absolutely a no-no. It's not the right thing to do at all, no. And I don't think student midwives should be unsupervised managing labour and giving care either, for the same reasons. Oxytocin, yeah, we need fridges for oxytocin. Undoubtedly, there should be a small fridge on every labour ward that is working. That requires a reliable supply of electricity, unless you've got a gas fridge. But we do need, oxytocin, you know, will be disabled if it's not kept at the right temperature. So, but I would say as well, there's more, I mean, uterine atony is responsible for 70% of postpartum hemorrhages. There's another 30%. And if you keep giving oxytocin and you've got a different reason, like a lump of retained placenta, you're not going to solve the problem, or some tear high up in the vagina that nobody's spotted. So we mustn't forget, you know, a lot of big studies think, oh, oxytocin given appropriately in the third stage is the solution to PPH. It's the solution to 70% of the PPHs. But if we keep giving it and keep giving it, as Karen said, when the reason is different, the woman will be bound to continue to bleed. You know, we've got the 4 T's, haven't we? It's not just tone. There's the other T's that count for PPH. So we must, you know, explore further in the management of the woman. And this is what we try to teach people. In the advanced course, we've got a specific session on post-cesarean hemorrhage that very much looks at the other causes as well. Thank you.
Thank you very much. We need to appreciate Helen and Fiona, and then we go for tea. We hope to meet you in the next session. So let's go for tea. How many minutes? 15. I think 15 is enough because it's right out here. So 15 minutes, our timekeeper kindly. Purity. Make sure that we are back after 15 minutes. remind us to come back after 15 minutes. Thank you everyone for your active participation. We hope to meet in the next session. Thank you.
My name is Veronica Musiega. I'm a registered nurse, midwife. I work in Vihiga County where I coordinate reproductive health services within the county at county level. I will say that Vihiga really benefited in the FCDO trainings, especially EMOC, where we have been able to train a very, I think over almost even up to 180 healthcare providers on emergency and obstetric care. And we've also been able to train our doctors, our theatre team on advanced emergency care that I think almost up to more than, I will say around more than 10, yes. And following those trainings, I think we've really seen a reduction in maternal mortalities, because initially we used to record 10 above. But following the trainings that we've had, we've really been able to reduce, because I can say for the year 2019, we lost around 8 mothers. The year 2020, we lost around 5 mothers. Then 2021, that is last year, I think we lost, is it about 7? And so far this year again, we have had a further reduction, so that for the financial year 2021-2022, that is July 2021 to June 2022, I think we have lost so far 3 mothers.
LSTM has been supporting Uasin Gishu for quite some time. We've had, I think, more than 8 EMOC trainings. The first trainings were fully funded by LSTM, but I think the last 4 or 5 were partnered between LSTM and the county. And once after the trainings were done, we were able to have a pool of mentors, courtesy of LSTM. And so currently, we are actually able, almost all our facilities do have trained mentors who are able to mentor their colleagues on the various skills in maternal and newborn. And with that, that has actually translated to an increase of skilled birth attendance in Uasin Gishu County, and a reduction in the necessary referrals from the lower facility to the higher facility.
And most of our healthcare providers are now competent enough to provide most of the obstetric emergencies, including emergency resuscitation of the mother. They are able even to use the pathographs very well, and be able to monitor, detect obstructed labor early enough, and even call for ambulance early, or even seek for help early enough. Then quite a number of them, again, are able, when there is postpartum hemorrhage, they have really learnt a lot. They have able to put up IV fluids very fast, and even put up interventions to reduce the bleeding. That is using the Dr. ABC approach. And then even use of the UBT. By the time they even refer our clients to the main referral hospital, you'll find that even a uterine balloon tamponade has been put, and they've really tried very hard to reduce these mortalities.